Hello students, welcome to this session. Let's study gram-negative cocci, Neisseria, Meningococci and Gonococci. So let's see Neisseria meningitidis, that is meningococcus. So morphology: capsulated gram-negative diplococci with adjacent sites flat, ledge shape or half moon shape. Virulence factors: capsular polysaccharide, 13 serogroups A, B, C, X, Y, W 135 account for the majority of cases of invasive disease. Non-capsulated, non-pathogenic. Outer membrane protein, LPS and endotoxin, IgA proteases, transferrin binding proteins. Epidemiology: risk factors that promote colonization include overcrowding and semi-closed communities seen in school, military, refugee camps, traveler, smoking, viral and mycoplasma infection of respiratory tract. Risk factors that promote disease: deficiency of complement component C5, C9, and hypoglobulinemia and hyposplenism. Pathogenesis: source only human, nasopharyngeal carriers, many children. Mode of transmission: droplet inhalation. Portal of entry: nasopharynx. Spread of infection from nasopharynx to meninges either by hematogenous route causing septicemia. Most common: direct spread along the olfactory nerve through cribriform plate through conjunctiva. Rare. Clinical manifestations may be asymptomatic, only colonization, most common. Rash, non-blanching rash, petechial or purpuric in 80% of patients. Septicemia, endotoxin-induced endothelial injury, increased vascular permeability and intravascular thrombosis. Waterhouse-Friderichsen syndrome, fulminant meningococcemia, large purpuric rashes, shock, TIC, bilateral adrenal hemorrhage, and multi-organ failure. So, meningitis: list of organisms: acute bacterial meningitis, pneumococcus, meningococcus, H. influenzae, listeria, streptococcus agalacti, gram-negative bacilla such as E. coli, acute viral meningitis, enterovirus, herpes virus, chronic meningitis, bacterial, M. tuberculosis, viral, parasitic and fungal agents, cryptococcus. Laboratory diagnosis: specimen collection, cerebrospinal fluid, blood, skin scraping from petechial rashes. CSF processed immediately, never be refrigerated. Meningococci may die on refrigeration. Blood culture in BHI broth. Nasopharyngeal swab, pus, scrapings from rashes carried in transport media such as Stewart medium, that is selective media, Martin medium, New York City medium. CSF examination: first portion, superintend biochemical analysis, capsular antigen test, deposit, gram stain. Second portion, inoculated on enriched media under 5 to 10% CO2, blood agar, chocolate agar. Third portion, inoculated into enriched broth, that is BHI broth. CSF microscopic examination: stained by gram staining, gram-negative diplococci with adjacent sites flat, rings or half moon shape, present inside the polymorphs and often extracellular also. Culture: selective media, that is Martin medium or New York City medium is used, and then growth is confirmed by biochemical tests. So catalase and oxidase positive, ferment glucose and maltose but not sucrose. And molecular diagnosis can be helpful. Serology: antibodies to capsular antigens, that is done by ELISA. It is retrospective diagnosis of disease to know response to vaccination, diagnosis of chronic meningococcemia. Treatment: third generation cephalosporins is drug of choice. Penicillin can also be given. However, reduced sensitivity reported from few countries. Symptomatic treatment such as aggressive fluid resuscitation for shock and measures to decrease intracranial pressure. Prevention: chemoprophylaxis for eradicating colonization of close contacts. Ceftriaxone, drug of choice. Alternative: rifampicin, ciprofloxacin. Immunoprophylaxis: polysaccharide vaccine, bivalent A and C or quadrivalent ACY-W 135. 2 doses, children of 3 to 18 months. Single dose more than 2 years. Efficacy 95%. Duration is 3 to 5 years for protection. No vaccine for serogroup B capsule, less immunogenic. and encephalogenic. Conjugated vaccine can be given to children less than 3 years. Indication: high risk people, contacts of patients during outbreak, splenic dysfunction, terminal complement component deficiency, taking eculizumab therapy, laboratory staff at risk. Summary of Neisseria meningitidis, that is meningococcus. Morphology: gram-negative cocci in pair, one side flat, one side convex, so they are lens-shaped. Pathogenicity: meningitis, 3 to 5 years of age. Symptoms: fever, vomiting, headache, and neck stiffness. Source: only humans. Nasopharyngeal carrier: mainly children. Mode of transmission: droplet inhalation. Portal of entry: nasopharynx. Spread of infection from nasopharynx to meninges. Laboratory diagnosis: specimen collection, cerebrospinal fluid and blood and skin scraping from petechial rashes. CSF processed immediately. CSF microscopy: gram-negative diplococci with adjacent sides flat, lens or half moon shape present inside the polymorphs. Culture: blood culture in BHI broth, nasopharyngeal swabs, scraping from rash carried in transport media, that is towards medium, selective media, Thyr-Martin medium, Neoxity medium. Biochemicals for confirmation of colonies: glucose maltose fermentation positive, oxidates positive.
So, sexually transmitted infections are a group of communicable diseases which are transmitted by sexual contact. Now, let's see infections, sexually transmitted infections, and causative agents of that. So, in both sexes, genito-ulcerative disease is there, and in that infection is syphilis. It is caused by Trypanosoma pallidum. Chancroid caused by Haemophilus ducrei. Genital herpes caused by herpes simplex virus. Lymphogranuloma venereum caused by Chlamydia trachomatis. Donovanosis caused by Klebsiella granulomatis. Urethritis, in that gonococcal urethritis, it is caused by Neisseria gonorrhoeae. Non-gonococcal urethritis, NGU, caused by Chlamydia trachomatis, that is D to K types. Then genital mycoplasma, in that ureaplasma urealyticum, mycoplasma genitalium, mycoplasma hominis. Then herpes simplex virus, Candida albicans, Trichomonas vaginalis. Hello everyone, welcome to this session. So today we are going to study sexually transmitted infections, and in that we will study gonococcus in detail, that is Neisseria gonorrhoeae. So first we will see morphology. In that they are gram-negative diplococci. Size is 0.6 to 1 micron in diameter. They are kidney or bean shaped. They are non-motile, non-sporing, non-capsulated, and they are fastidious. That is, they require rich nutrients, that is complex medium containing carbon dioxide. They are delicate microorganisms. So for that they need transport media, that we will see later. So growth characteristics, they are fastidious. They grow based on chocolate agar, Muller-Hinton agar. Then selective media for this Neisseria gonorrhoeae is Thyr-Martin media and modified Thyr-Martin media. Then they are characteristically facultative anaerobes and capnophilic. So capnophilic means they grow better in presence of carbon dioxide, that is 5 to 10% CO2. And the characteristics of the colonies, they are divided into T1, T2, T3, T4 strains. Biochemically, they are catalase positive, oxidase positive. So oxidase positive is a typical feature for the gonorrhea bacteria. And then glucose fermentation seen, maltose lactose fermentation, sucrose, they are not seen. And this is a contrast point with the meningococcus. So in that glucose and maltose is fermented. But in gonococcus only glucose is fermented. Now let's study virulence factors of Neisseria gonorrhoeae which causes gonococcal urethritis. So first they are pili which help in attachment to host cells and they are antiphagocytic. Then pore protein, that is protein 1, forms pores in outer membrane and prevents phagolysosome fusion in neutrophils. OPA protein, that is protein 2, mediates attachment to cells. RNP protein, that is protein 3, protects surface antigens from bactericidal antibodies. Iron binding proteins, that is transferrin, lactoferrin, hemoglobin binding proteins, they all mediate acquisition of iron from host cells for bacterial growth. Then lipo-oligosaccharide, LOS, they are endotoxic, which produces endotoxin. Then IgA protease and antibiotic resistance. So these all help in causing gonococcal urethritis. So they all are the virulence factors. Now let's see pathogenesis. So how this occurs. Then with help of pili, the bacilli get attached with the host cells. So that is first step, adhesion. Then endocytosis, and then they penetrate inside the cells. Then there they multiply because there is no action of the lytic enzyme. So they multiply and then they produce different virulence factors. With help of all these virulence factors they multiply, and because of the endotoxic activity of LOS, that is lipo-oligosaccharide, all these help in causing inflammation, and then it causes urethritis. Now let's study clinical presentation of gonococcal urethritis in males, females and neonates. So it is mainly venereal disease caused by sexual contact. Incubation period is 2 to 8 days. So in mainly this infection seen are urethritis. It is mucopurulent discharge. Then chronic urethritis is there, and in that you can see stricture formation. Periurethral tissue abscesses can be there. Multiple discharging sinuses, and it is also called as water can perineum. In women, it is cervicitis, endometritis, vaginitis, mainly in prepubertal girls, and pelvic inflammatory disease, salpingitis. So, in women are mainly carriers of this infection. So, in both sexes, other infections you can see, that is proctitis, conjunctivitis. That conjunctivitis is because of the auto-inoculation and bacteremia. So in newborn, they are non-venereal. So neonates may get infected through passage of the birth canal. So in that you can see gonococcal ophthalmia, gonococcal bacteremia, skin lesions, suppurative arthritis. And it is also called as ophthalmia neonatorum. Disseminated gonococcal infection. So in that 1 to 3% are disseminated. So in that you can see fever, polyarthritis, tenosynovitis, pustular, hemorrhagic skin rash, and this is followed by arthritis of the large joints. Let's study epidemiology. The incidence is decreased in developed countries, but in developing countries it is still there. And because the cases are decreased because of the underreporting due to stigma of this disease. The host mainly it is human disease, and source is asymptomatic female carriers or sometimes patient. The transmission is sexual contact mainly, that is venereal, and mother to baby during birth. Now let's study laboratory diagnosis of this disease. So these are the steps: sample collection, then microscopy, culture, biochemicals and serology. So the laboratory diagnosis is essential for confirmation, then specific therapy and prevention and control. So in urethritis, you can take urethral discharge, and then urethral discharge can be collected in a swab. But swab should be used are Dacron or rayon swab, because the cotton swabs they contain fatty acid and which inhibit the growth of the bacteria, or they kill bacteria. And then if delay is there, you have to quickly transport it to the laboratory. But if delay is there, then you have to use transport media, that is towards transport media or amidst transport media, because these bacteria are very delicate, so we have to use transport media. So that transport media allows the survival of the bacteria. So the specimen can be urethral swab in male and cervical swab in females, and Dacron and rayon swabs are used preferably. In chronic urethritis, the sample collection is very less, so in that prosthetic massage should be given or morning drop of the secretion is used. So in urethritis, urethral discharge, or if patient is complaining of arthritis, gonococcal arthritis, then joint aspirate, their samples you can take with help of charcoal coated swabs, and then you can keep in Stewart transport medium or Amiz medium. So in endocervical culture has sensitivity 80 to 90% because in cervical swabs contain commensal Neisseria. So in that we have to use selective media, that is Thayer-Martin medium. So it is chocolate agar with antibiotics like vancomycin, colistin, nystatin, or modified Thayer-Martin medium can be used. So they are selective culture medias which allow the growth of selectively of Neisseria gonorrhoeae and inhibit the growth of commensal bacteria. So these are chocolate agar based mediums containing vancomycin which inhibit staphylococci, streptococci, diphtheroids, colistin which inhibit gram negative bacteria and saprophytic Neisseria. Then nystatin, which inhibit molds and yeast, which are present in genital or rectal area. Then trimethoprim is added in that which inhibits swarming protease species of the bacteria. So this support the growth of Neisseria gonorrhoeae and Neisseria meningitidis. So these are the selective culture media for the Neisseria group. Then after that, sample collection and transportation of the sample, we have to do microscopic examination. So that we do by gram staining. So in gram staining, we can see gram negative intracellular kidney shaped diplococci. They are present in pair, so that is why they are called as diplococci. And they are kidney shaped and the concave surface of bacteria facing to each other. So that is present arrangement of this bacteria. Then for the isolation of the bacteria, this isolation selective medias are used, that is Thayer-Martin culture media or modified Thayer-Martin culture media, that is they are chocolate agar with added antibiotics to inhibit the commensal bacteria, and they require 5 to 10% of the carbon dioxide because they are capnophilic bacteria. They grow better in presence of the carbon dioxide, that is 5 to 10%. So here you can use the in culture incubation system, that is of candle jar, which gives 5 to 10% carbon dioxide. So colonies grown on selective culture media, that is Thayer-Martin or modified Thayer-Martin culture media. So they are large, 1.5 to 2.5 mm in diameter. They are grey, convex with crenated margins and raised oblique center. The biochemicals of the gonococci, they are catalase positive, they are oxidase positive. They ferment only glucose but not maltose and sucrose. So this is in contrast to meningitidis, that is meningococci, which ferment glucose and maltose both. So this is a biochemical pattern of the gonococci. So here you can see oxidase positive. Then only glucose is fermented. Serological identification can be done by ELISA, latex agglutination, hemoagglutination, radioimmunoassay. Then in molecular methods, we can use DNA probes and PCR method. So nucleic acid amplification test can be used, but that is PCR method for the detection of N. gonorrhoeae from the clinical specimens targeting 16S and 23S rRNA gene. So this is lab diagnosis. Then after that we can see antibiotic sensitivity test. So on Muller-Hinton agar, we can put antibiotics like ceftriaxone, ciprofloxacin, ofloxacin, doxycycline, erythromycin, azithromycin, and then we can see antibiotic sensitivity report. So treatment for gonococcal infections, mostly third generation cephalosporin is a drug of choice in uncomplicated gonococcal infection. And in that, both sexual partners should be treated simultaneously. So ceftriaxone 250 mg given IM single dose or cefixime 400 mg given orally single dose. So if coexisting chlamydial infection is seen, then you can use azithromycin or doxycycline. As no vaccination is available for gonococci till now, so prevention of this disease can be done by early detection of cases, treatment of both the partners simultaneously, tracing of contacts, and health education should be given about safe sex practices by use of condoms.
Difference between meningococcus and gonococcus. So meningococcus N meningitidis capsulated, N gonorrhoeae non-capsulated. Meningococcus diplococci adjacent sides flat. In gonococci diplococci adjacent sides concave. Meningococcus ferment glucose and maltose. Gonococcus ferment only glucose. The meningococcus rarely have plasmids. In gonorrhoeae usually possess plasmids coding for drug resistance genes. Meningococcus both intra and extracellular. In gonorrhoeae, predominantly intracellular. Meningococcus colony circular, Gonococcal colony vary in size with irregular margin. Meningococcus habitat nasopharynx, Gonococcus habitat genital tract, urethra, cervix, rarely pharynx. Summary of Gonococcal Neisseria gonorrhoeae. Morphology gram-negative cocci in pair. Shape kidney shape. Pathogenicity gonorrhea. In male acute urethritis. purulent urethral discharge, complication epididymitis, prostatitis, and balanitis, water can perineum. Female more asymptomatic, symptomatic mucopurulent cervicitis, vulvovaginitis in peripubertal girls and postmenopausal women because vagina is thinned out at higher pH. In adult female, resistant to gonococcal infection because of the low pH and thick stratified squamous epithelium of the vagina. Neonates, ophthalmia neonatorum. Lab diagnosis specimen, Dacron or Rayan swabs. Cotton is inhibitory to gonococci. Urethral swab in men, prostatic massage, and cervical swab in women. Transport media, Stewart and Amis media. Microscopy, gram-negative intracellular kidney-shaped diplococci. Culture, selective media, Thyromartin, chocolate agar with vancomycin, colistin, and nystatin. Modified New York City medium. Identification biochemicals, catalase oxidase positive, glucose maltose, only glucose is fermented, automated multi-top molecular NAT and PCR methods can be done.
Hope you find this session useful for your understanding and for your exams. Thank you.